Good evening, all the aspirants present here. The debriefing session will be taken by Dr. Asif Iqbal, sir. Sir, you can share your site.
Yeah. Yeah, good evening all. Today I will talk about my respiratory cases. So my
Aspirants, this is going to be a very interactive session. Please do unmute your mic, or else you can also drop your answer in the chat box.
okay. So I think Maria has given this exam, so he knows most of the answer. And still we continue. Let's see. So the case was 62-year-old man presented with a fever, productive cough and breathlessness for 4 days and presented in the emergency with blood pressure 82/86 and heart rate 122, respiratory rate 34, SpO2 is 88 and 15-liter oxygen, temperature 39.5 degrees Celsius, CXR right, lower lobe consolidation and lactate is 4.6. You may get the small pinpoint scenario or big scenario, but remember you have to either you can note down the values, important values on your piece of paper, or you have to remember that because the next question is depend on this variant. So, and when you are giving answer, is not a generalized answer. Obviously, there are some point will be considered as a generalized, but you have to give more specific about the patient which you are treating. Okay. So all are the scenario will given by the ESICM, that is a real patient data. So always try to remember the figure and the fact, and also the abnormal values which help to give you the proper answer. So here the case is 62 years with the hypotensive and the tachycardic, tachypnea is there, temperature is high, lactate is high, not giving information about mental status, but in real scenario, obviously they will give you the mental status. This is the chest X-ray. So right lower and lower jaw pneumonia. So first question is, how do you assess the severity? So regarding the assessment of the severity, you have to utter the name of certain severity scoring system, like your CROB 62, which is very common in UK, and also ATS guideline for there are major criteria and minor criteria, and also there is a CPI score. But first you utter this CROB 65 because scenario will give related to that. You can and scoring that how much is the CROB score, and CROB score is help you not only the prognosticate, also it guide you where you will admit the patient, whether in the ward or in the ICU. And I hope everybody knows the CROP 65 and initial manage. Then the question will come the initial management priority. Whatever the scenario, they will give you the this initial management priority. And when they will utter the initial management priority, they prefer you give answer like A, B, C, D, E, F order: airway, breathing, circulation, disability, and exposure. For trauma, disability and exposure is important. For the respiratory case, airway, breathing, circulation is very important. So initial management priority will be take care of the airway, take care of the breathing and the circulation, because your patient is tachypneic, tachycardic, hypoxia is there, and also the hypotension is there. So then the question is, what are the indication for mechanical ventilation and this patient? So you can argue that I'm not going to intubation immediately. First, I will try with the oxygen supplement with NIV or HFNC, whatever your preferable things, and you have to reason for that, and you have to know how will you monitor these things. So if you give the NIV, then you have to tell that since I'm not knowing the mental status of the patient, if the patient is not disoriented, not comatose, I can try with NIV, or I can try with the HFNC, and I will continuously monitor the patient vitals. If NIV failure, like after half an hour, I will do AVG, and if the desaturation worsen and consciousness worsen, or the AVG is altered, then I will go for the mechanical ventilation. If you are prefer the HFNC, again you will say that I will prefer HFNC, but I will monitor every 2 hourly, and every continuously monitor every after 2 hours or 1 hours. I will do AVG. I will see the condition, I mean, of the blood gases. If the oxygenation is not improved, or the redox score is more than 3, then I will consider that HFNC failure. I'll go for the mechanical ventilation. And if the patient giving the saturation giving much less, the big pneumonia, you can directly go for intubation. You can say that patient is altered sensorium, patient is in a shock, and comatose. So I will go for the mechanical ventilation. They will, in this particular question, they will judge your knowledge and your practical knowledge about handling of the patient. Nowadays, for the last year also, they ask about the corticosteroid status in your ICU. So in pneumonia, so severe pneumonia, the few of you given a good answer on the corticosteroid state, that in a severe pneumonia it is indicated, or in patient when patient is shock and pneumonia sepsis, then stage steroid has a good role, but it is not indicated when it is a case of influenza. You will not give. Biomarker for prognosis. So COP65, ATS, major and minor criteria, and airway, then initial management. These are the model answer. Oxygen, high flow nasal, NIV, type 1 respiratory failure. Then you have to also mention that 2 set blood culture, you will say before antibiotic, broad spectrum antibiotic you can consider here, preferably BL/BLI with macrolides. If because the UK and India practice little bit different, we follow the Indian guideline. They follow the ESICM guideline, but if you utter the BL/BLI and macrolide, it is okay, because here in India most of the BL/BLI is piperacillin tazobactam, and macrolide is either doxycycline or azithromycin or clarithromycin. So if you give the BL/BLI and the broad spectrum BL/BLI and macrolide, it give you the they will give you the number. Then because patient is hypotensive, so you have to give the crystalloid fluid resuscitation and norepinephrine to maintain the MAP and evaluate source control and other organ support. What indication the mechanical ventilation? Refractory hypoxia, PO2 FiO2 less than 100, exhausted or hypercapnic. When considered corticosteroid, it's a septic shock, or in a severe pneumonia. Biomarker for prognosis, everybody was right that procalcitonin and the CRP is the biomarker. Then the question was, what are the atypical causes for the possible pneumonia. Atypical causes is Legionella, Mycoplasma, Chlamydia, Coxiella. Everybody was pretty good on that answer. Key diagnostic clue is for atypical is hyponatremia, GI syndrome, transaminitis. Legionella can cause these things, so confirmed by urinary antigen test. Empirical and targeted therapy, again, empirical therapy, macrolide erythromycin or fluoroquinolone, levofloxacin. But in India, we do not use the fluoroquinolone. So that's why I'm telling that you can utter the macrolides. That is enough. And infection control, you have to, nobody has uttered these things. That hand washing, it can be spread person to person, environmental investigation outbreak. So if they can ask about the infection control, then you have to tell about the protective measures. And here prognostic biomarker, a prognosis marker is if you not give macrolides, then probably patient gets worsened. So then there are another scenario like the patient respiratory failure. You are putting ventilator of this patient. So what will be your ventilator strategy? When you consider ECMO, your fluid vasopressor strategy, antibiotic duration, and prognostic. Here is the mortal answer that always in critical care exam, if anything ventilator strategy, be it a patient on ECMO or be it patient on your mechanical ventilator is kind of pneumonia or ARDS, always say the lung protective ventilation. And then they will ask what you want to mean the lung protective ventilation. Then you will utter there are four criteria. One is the tidal volume. It should be 4 to 6 ml per kg ideal body weight. Plateau should be kept less than 30, and PEEP as per the ARDS net protocol. And third thing is not included here. That is the ESICM 2023, they have included the mechanical patient. Mechanical patient or the driving patient. Driving patient should be less than 15 or mechanical patient less than 17. And you can go for the prone ventilation. And when to consider ECMO is when the patient is a refractory hypoxia, PO2, FiO2 less than 80, more than 6 hours, despite your optimal setting. And optimal setting, proning, everything you can utter. And the fluid or vasopressor strategy, conservative fluid and norepinephrine is the first line. First, your fluid strategy will be conservative because the FACTS trial shows that the conservative fluid strategy has a better mortality outcome. So you give initial resuscitation fluid, then you have to de-escalate the fluid, and you have to use the noradrenaline and vasopressin to keep MAP more than 65. And antibiotic duration, there are trials showing that 7 days antibiotic is good enough. There is no difference between 7 days versus 14 days IV antibiotic. And prognostic scoring here, the SOFA Apache 2 is your prognostic scoring for mortality. And when to consider corticosteroid, septic shock needing vasopressor despite fluid, you can use hydrocortisone 200 milligram per day, either in the infusion or in an intermittent bolus. Biomarker, okay. Then I have given this scenario. Usually from the community acquired pneumonia, they can go straightway in the ARDS, or they can do the complication like empyema. And from empyema, they again enter the ARDS. So this is a CT scan showing that there is a right-sided pleural collection, fluid and the air, and the fluid showing that the glucose is low, pH is low, LDH high, neutrophilic predominantly. So it is you are dealing with the complication of the community acquired pneumonia, that is your empyema thoracic. So what will be their question was that what are the likely causative organism? So likely causative organism is Streptococcus pneumoniae, Staphylococcus aureus, and anaerobe bacteroids, and post-influenza or hospital exposure. If there is a repeated hospital exposure is there, immunocompromised patient, then you can consider MRSA or pseudomonal. How do you confirm the empyema thoracic? Diagnostic thoracocentrosis. The pH should be less than 7.2, and the ultrasound evidence is loculated and separation. And you have another criteria, the LDH should be more than 3 times of the your normal value. Protein should be higher than the plasma, at least 1.5 times, and glucose will be low, and the neutrophil count is more than 400 is the criteria to diagnose empyema thoracic. Then outline the management. Again, you have to talk about the immediate coverage of the antibiotic, and you have to keep the anti-pseudomonal antibiotic here, and the source control. You alter the source control one by interthoracic tube drainage, or sometime if there is a loculated things, then interpleural fibrinolytic. You can use your streptokinase or tissue plasminogen activator like tenecteplase. And if there is a more loculated and the thickened septation, then you can go for the VAT decortication. Supportive care here, the poor analgesia, oxygen, fluid, glycemic control, TVT prophylaxis is your supportive care. When you will consider surgical referral, after when either the after giving the drain, there is a still persistent collection and not or it is organizing the empyema or trapped lung or persistent sepsis, not improving the patient, then VAT and thoracotomy consider. And what are the prognostic indicator? One is the age, comorbidity, and multiloculated effusion, delayed drainage, polymicrobial infection, higher mortality, early drainage less than 48 hours, and improve outcome. So potential complication is sepsis, septic shock, bronchopleural fistula, fibrothorax, restrictive lung disease, pleural phase recurrence, empyema necessitas. So this is the stepwise approach: empirical antibiotic, then drain, then if not draining, then TPA, and you can use TPA or surgical, then follow up. Now coming to the variant 3, in despite of drainage of IV antibiotic, he become tachypneic, hypoxic, requiring intubation, chest X-ray showing bilateral diffuse infiltrate, no pneumothorax, no cardiac failure. So this was the question: how do you confirm ARDS? How will you ventilate this patient? Again, the model answer is you have to utter the Berlin definition about confirmation of the ARDS. And how will you categorize the ARDS? By PO2 FiO2 criteria. And then again the your ventilator strategy, lung protective strategy already mentioned. And here you have to mention the permissible hypercapnia, allowed pH more than 7.20, avoid recruitment maneuver except transiently, because the all the trial related to recruitment maneuver is failure. And monitor transpulmonary pressure if obese or chest wall restricted. And recent update ESICM 23, driving pressure reduction and mechanical power less than 17 joule per minute improve survival. Then how will you manage fluid in ARDS? Again, conservative fluid strategy, fact trials, M0 to negative fluid balance once hemodynamically stable. Use dynamic indices, your echo or pulse pressure variation and systolic stroke volume variation. You can use in a hemodynamic compromised patient, and avoid excessive crystalloid, use vasopressor, maintain PAM. Diuretics if euvolumic and oxygenation is poor. And how do you modify antibiotic therapy here? Here you can go for the broad spectrum coverage and de-escalate once the culture available. And duration again 7 day. If clinical improvement, ensure source control, confirm empyema adequately drained, and monitor serial procalcitonin, which help you in the taking decision of the discontinuation. But PCT has no diagnostic value, it has only prognostic value. So on the basis of PCT you can't prescribe your antibiotic. Then if you utter these things, then you will fail. What is your sedation and paralysis strategy? Light sedation is recommended, and early in severe ARDS, sedation and paralysis has good outcome. There are two trials, one the Accuracy trial, showing that in severe ARDS and early stage, uh, 2 to 3 days with sedation and paralysis has good result. Avoid prolonged neuromuscular blocking agent. There's another trial is a Rose trial showing that prolonged neuromuscular blocking, no mortality benefit. Delayed sedation interruption, prefer propofol or midazolam, adjunct fentanyl or dexmedetomidine can be used in a long-term sedation. And when will you start phone ventilation and what are the benefit? The indication is PO2, FiO2 less than 150, FiO2 is more than 0.6, and PEEP is more than 10. Start within first 36 hours, maintain more than 16 per day. The Procedure trial has showing that benefit, and it reduces the mortality, improve PQ mismatch, and the dorsal recruitment. And during proning, you maintain sedation, NBM during proning, and stop when PO2, FiO2 more than 150, and FiO2 is zero 0.6 in supine. So what are the recent controversy update in ARDS management? If they ask, then the controversy regarding the high PEEP versus low PEEP, no uniform survival benefit, and which patient good in the high PEEP and good in the low PEEP. But recently, the paper published that in a phenotyping, there are ARDS has two broad phenotype. One is a hyperinflammatory group, and other is a hypoinflammatory group. In hyperinflammatory group, showing that high PEEP is beneficial, and in opposite hypoinflammatory group, high PEEP is detrimental, where opposite happen on the other group. And recruitment maneuver, the prolonged staircase recruitment increase mortality. So the proning also one of the recruitment maneuver which has a good mortality benefit. Corticosteroid again, Dextra ARDS trial in NEGM published 2022, dexamethasone 20 to 10 milligram, 10 days decrease ventilator day and mortality. benefit, but there are a lot of controversy on use of dexamethasone for long term. Fluid management, conservative approach is reform in classic 2022, and regarding again the fact trial showing that the conservative fluid management is good, but the recent data showing that where the hyperinflammatory phenotype, they are better on the conservative fluid management, but the hypoinflammatory better on the liberal fluid management. Vitamin C, stem cell, statin, no mortality benefit, subphenotyping, hyper and hypoinflammatory, potential for future precision therapy. This is live trial. And high flow nasal oxygen NIV limited role once moderate ARDS, risk of delayed intubation and increased mortality. The prognosis and outcome, the mortality is it is depend upon the category of ARDS, and poor prognostic factor is age, SOFA score, shock, AKI barotrauma, delayed inponing, and ECMO. Survivor risk of post-ARDS fibrosis, long-term neuromuscular weakness can happen. So this is few evidence trial and the recommendation, ventilation, ARDS net protocol, fluid fact trial. There are trial you have to remember regarding the neuromuscular blocking agent, Acuris trial, prone, Posiva, ECMO. You can utter the Eolia trial, Caesar trial, steroids, DEXA-ARDS, and antibiotic related to IDSA. Now, Vinian 4, this patient again secondary to community acquired pneumonia, ARDS, you have given all the management, still the PO2, FiO2 is low, and with your conventional management and hemodynamically stable. So what you will do, yes, definitely you can go for the ECMO. So ECMO cannulation, and there are lot of question can ask on the ECMO, PV ECMO. This time is high probability you may ask about the ECMO, either VA ECMO or VV ECMO. So here you have to give the VV ECMO. I have taken the long class on the ECMO. ECMO, you have to know the cannulation. ECMO, you have to know the circuit. You have to know the maintenance and the complication, and how do you ventilate during ECMO. So little bit consider venovenous ECMO in this case when PO2 FiO2 is less than 80 for more than 6 hours, pH is less than 7.25 with PSU to more than 60 for more than 6 hours despite optimal ventilation. That is ULA NEGM published in 2018. And there are recent paper also showing that if you offer early ECMO in a severe ARDS patient has better mortality benefit. And you can consider when the prone failure and your other strategy. So this is the indication for VV ECMO in this case: severe hypoxia, severe hypercapnia, excessive plateau pressure. So describe your cannulation and circuit. Again, you have to know the nomenclature. VV means the drainage cannula and the return cannula both in the vein, either femoral or jugular or femorophemoral. and and it can be femorojugular or it can be dual lumen, where the drainage cannula in the IVC and the drainage cannula in the IVC or return cannula in the just right atrium, opening in the right atrium. The blood flow usually 60 to 80 ml per kg per minute, 4 to 5 liter per minute. Sweep gas flow is 0.5 to 1 liter, 0.5 to 1 into blood flow. and titrate PaCO2. If your carbon dioxide is more, then you increase the sweep flow, or if your carbon dioxide low, then you can adjust the sweep flow lower side. If FiO2 is actually in ECMO, it is called DO2. DO2 you always start with 1, then reduce gradually. And heparin anticoagulant, your target ACT 180 to 20, or if you use the anti 10 activated factor, zero point 0.3 to zero point 0.7 unit per ml. Usually, most of the places, the heparin is universally used, so you can utter the heparin. Don't do much more complicated. If examiner asks what other you can use, then you can name the other anticoagulant. What is your target during VPECMO maintenance? Everybody telling good thing, but there are few mistakes. One is the targeted maintenance is the oxygen, then carbon dioxide. Then you have to monitor the circuit flow and prevent chattering. You have to know what is the chattering. Chattering means shaking of the cannula, and why it is happen. Either patient is hypovolemic or there is a kinking, so flow disturbance is there. So you have to optimize the flow. How? You do focus. If the patient is hypovolemic, you have to give the replacement, and if there is a kinking, then you have to straighten up. And ventilator, lung rest strategy, where you keep the volume as low as possible, tidal volume as low as possible. Keep PEEP is around 10 to 15, and target plateau less than 25, FiO2 less than 0.4. And your hemodynamics target, maintain MAP more than 65. Anticoagulation monitoring, daily hemolysis check, and infection control, sterile circuit management. Infection control standard protocol you will maintain. So that is your VV ECMO maintenance. So you have to be categorize your answer. At one is your target, gaseous target, then your maintenance and monitoring is everything is included. Then what are the major complication? Major complication in bleeding, thrombosis, infection, hemolysis, renal dysfunction, limb ischemia, and neurologic. In this area, they will give you scenario, like they will say, okay, you are continuing with the VV ECMO, and suddenly you see that there is a the drainage cannula in the right side, and the right leg has swollen up. So what is your provisional diagnosis, and how will you manage? So that means when there is a swelling, means there is a chance of bleeding. So there is a rupture of the femoral vein. There is a bleeding hematoma. You have to manage this hematoma. And they can ask also that you have given the femoral VV ECMO, and there is a ischemia in the distal limb. What will you do? Like this type of scenario they will give, and they will judge your answer whether you know or not. Then how will you ventilate? Another 5 minutes. Well, how do you ventilate during VV ECMO? Lung risk strategy, uh, 3-4 ml per kg, PEEP 10 to 15, respiratory rate 10 to 15, FR 2.3.5. Aim of plateau is this is a lung risk strategy already mentioned. What is your sedation approach in ECMO? Again, in the ECMO, initially you go for the deep sedation, but after 36 or 48 hours, you have to go for the light sedation. And then when the patient settle down, you can off the sedation. Usually you do physiotherapy and all, daily sedation break, early physiotherapy, improve outcome. How do you assess regardless and platform of ECMO weak? Readiness of ECMO winning, readiness, lung compliance improve, FiO2 from the ventilator is requirement zero point 0.4, PEEP is less than 10, and your vasopressure requirement minimal, hemodynamically stable, and winning trial is sweep of test, reduce sweep gas gradually, and see that whether carbon dioxide increasing or not. If if you stop the sweep gas and the ventilator maintain the PO2 and PaCO2 and the pH, then your patient is ready for decannulation. And before decannulation, you have to clamp the cannula, and you have to wait for at least 1 hour or 2 hours and check the ABG. Is FG okay? Then your patient is absolutely ready for decannulation. You can go for the decannulation. So there is no rocket science. Immediately we will remove the cannula. And post decannulation care, 4 hour bed rest, compressive dressing, and repeat ABG. Yes, thank you. Mm, that is all about my respiratory CCS. If you have any question, you can ask at this point.
Any question, aspirants? You can clear your doubts here.
So at least those who have given exam, I think you have a clear guidelines. You got the clear guidelines. What will be your model answer? And anybody can ask question.
Sir, regarding chattering, can you explain once again? Chattering.
Chattering is actually in the monitoring. What are the things you will monitor in when your patient in ECMO, especially VV ECMO? One is the color. The drainage color will be blackish, and the return color means the blood coming from oxygenated to patient, that will be bright red. That is one. Chattering is the severing of the drainage cannula. So there will be bubble, or there will not bubble, there will be a shaking of this return cannula. This is called chattering. So why chattering happen? It is due to kinking of the drainage cannula. Either there is a kinking or obstruction or thrombosis, or there is a hypovolemic state of the patient. If the patient, so you have to identify, the management is, you have to identify why chattering happening. Chattering happening means there is a flow disturbance. So flow is gradually down. That's why there is a chattering happen. So you have the management is first you reduce the RAM. So when you reduce the RAM, it reduce the negative pressure. So negative suction will reduce. And third thing is that first thing is the check whether clot is there, kinking is there, or the volume status is there. Then you reduce the RAM, and if there is no clot, no kinking, and then definitely the volume status is low. You have to optimize the volume, and you have to optimize the RAM. So if the RAM is too high, it causes more negative. Usually in the drainage side, you have to maintain up to -50 to drain of the blood. If the RAM is too high, it create negative pressure more than 50 or more than 100, then there is a chance of scattering. Anything else?
Thank you, sir.
I think no question.
Sir, if you don't mind, show last slide, please.
Yes. Uh, just a minute. So last slide. What is happening? Microsoft PowerPoint share. Oh, why sharing is not happening? Just give me 1 minute. Okay. Is visible?
It's okay, thank you.
And this one, your prognostic outcome.
Yes, yes.
Okay.
Thank you, sir.